All right. Extremity trauma, the only thing that changed is we just added the cefazolin here. So if you got an amputated part or remember open fracture, we're going to give cefazolin, but we also put it in there to catch the amputated part. It's only for adults. For right now, we're only doing it for adults. But we will eventually go to pediatrics. I just didn't want to do all this at once. But yeah, we will. Good question. But right now, just 18 and above. Well, actually, technically, 15 and above. So sorry. Correct. Right. So use the definition of pediatric. If they're off the Broslow tape, if they're 49 kilograms or greater, or if they're 15 or older, ANSEF would be perfectly fine to get, because those kids are typically going to be just, and honestly, grandma ANSEF is not, that's perfectly fine. Not going. Now the 1 month old, but that'd be a whole different story if a 1 month old's got an open fracture. So, all right, so we've gone over this a bunch. Any questions about this? Because I know we've gone over this a lot. The only thing that really changed was the P's now changed to all B's. A little bit more guidance over here. You got somebody that's ambulatory, put a collar on them if you think they need one, move them to the stretcher and immobilize them to the stretcher. If they're non-ambulatory, absolutely use your long spine board to transfer them to the stretcher. They don't necessarily need to be kept on that long spine board. You can just use your spine board as a transfer device, put them on the cot, strap them to the cot. We took out the age. So age still important, and honestly just keep an index of suspicion. So if they're less than 5, it's harder to get a good exam. But kids less than 5, typically we normally have a car seat or something they can be trained, and the car seat itself actually does a great job at immobilization. So you can put a towel or something around their neck and have them in the car seat, and that actually probably immobilizes them better than anything else we've got. And then the person that's over 65, just remember, when we get over 65, we got more risk of breaking things and not having so much pain, especially folks who have renal disease or osteoporosis where their bones just aren't thick. So the main thing is just keep a high index of suspicion. However, the 65 doesn't necessarily mean that you got to be put on a long spine board. It just means you might put a collar on those folks more often than you might not someone else and strap them to the cot. Because remember, the elderly actually have the worst outcomes on a spine board. So increased pain, decreased respiratory reserve. So they actually have the worst benefit of a long spine board than anything else. But, just be aware that they are a little bit more prone to fractures. So spinal precautions would be much more important to maintain in that elderly person, even if they don't have that much complaint. So if they've got a good mechanism of injury, I'd err on the side of caution, put them in a collar, immobilize them to the cot, but not necessarily put them on a long spine board. And correct. Absolutely, they won't fit on a long spine board, right, absolutely. Yes. So, yes, you and everybody else, because when this study got done, it was called the Nexus study, had over 35,000 people in it, and the only thing that truly wasn't defined is what a distracting injury was. So, yes, that's a good question to have because nobody else knows the answer either. That is the biggest part of the subjective part of this exam of all of them. So in the study, they did define a few things. So if you had a degloving injury, so if your skin was ripped off your hand or foot, they considered that a distracting injury. I'd agree with that. If you had a proximal long bone fracture or a hip fracture, that was considered a distracting injury. That's actually the only things that they really put in that study. So yeah, typically it's going to be something so big that they could have you got to think of it in terms, they got some other injury that's so significant that that's going to make them ignore the pain in their neck. And that's possible, it can. So again, what that really will boil down to more than anything else is whether we're going to put them in a C-collar and protect their spine. Still not necessarily where you're going to put them on a backboard. So we really ought to be moving to very rare instances where we use a backboard. So not that a backboard can't be used, but it ought to be pretty rare when we have to use one. And we almost always should never transport somebody on a backboard. So we definitely shouldn't do any. Well, and that person would have been perfectly fine to put a collar on and then, 4-man log roll and then put them on a cot. So again, the key is spinal precautions, keeping the spine in alignment, but the backboard's never been proven to do that, and we know it doesn't. So the key is to think in terms now of protecting the spine, but the backboard has never ever has it ever been shown to actually protect the spine. Scoop is fantastic. Yeah, kind of. So big study got done a couple of years ago where they took the paramedic and they put bolts on his chin and his clavicles and his neck and had extricating that physical paramedic extricating him out of a car, through the front windshield, through the back deck, and then outside the door. They did a long spinal extrication, they did KED, and they did self-extrication where they just let the guy get out. So the high-speed photography showed that the least movement occurred when the patient just got himself out of the car, and the most movement happened when they put a KED on. So I don't know, and I still think KED is a very good device, but in that particular study, the KED actually showed more spinal movement than anything else. Yeah. So again, the main thing we got to get away from is equating spine board with spine protection. So spine protection is log rolling, making sure we keep all the C, the T, and the L spine in alignment. But the backboard's never ever shown to do that. So the real key is to kind of get away from thinking that the spine board is spine protection. Spine protection should be more about having enough people to either log roll if that's what you got to do, scoop stretcher to lift, keep that spine in alignment while you're transferring the patient. That's a good question. Honestly, I don't think you need one that much. Now, having said that, though, you got a car down a ditch, you got to slide a driver out of the seat onto a cot. That's a perfect time to put the spine board on the seat, slide the patient over to the board, put the patient on the cot, put the backboard back in the cabinet. So the backboard can be used for all sorts. I mean, you may need to carry somebody downstairs. So there's a lot of things that the backboard we can still use it for. So I'm not telling you not to use it because it's very effective. We've been using it for years to carry people. But think of it more as carrying people from the scene to the ambulance, not necessarily from the ambulance to the hospital. So you can still use it on scene for all sorts of stuff. But folks don't necessarily need to go to the hospital on a long spine board. But we still can use it. But scoop stretcher is great as long as you don't have the old one that won't work and it just pinches your fingers. So. But the scoop stretcher is great. All right. And the protocol, the procedure just changed with I do just highlight a couple of things that we changed the procedure, or maybe it was back in the pearls, I can't remember. Anyway, this just gives you a little bit more in depth about all the ways you can move people. But in the protocol, in the spinal protocol, we actually put in here, long spine boards are not considered standard of care in most cases. So we put that in there for protective language to show that it's not considered the standard of care. This protocol doesn't affect you guys, but it's our Narcan. Well, I guess it does affect you guys. First responders and law enforcement. And if you've got somebody that's awake or able to be awakened, don't do anything, call EMS. If they're unconscious, no breathing or agonal breathing, start hands-only CPR, get an AED, and then shoot Narcan in both nostrils. Allow 2 minutes. If they start breathing, put them in the recovery position. And if they were breathing shallow or slow, activate EMS. So this is a protocol for the first responders and law enforcement. So I know we've already had some utilizations of Narcan. Joseph, any comments about that one, buddy? We changed now it's correct, right? We're doing 2 milligrams on each side. All right. The only caveat I would say, when somebody squirts, just remember when we're training guys, we want to make sure they angle it toward the turbinates and then pinch the nose for just a few minutes to increase absorption. And for us, it's like when we're rolling up on scene and somebody just shot 2 milligrams of Narcan in somebody's nose, give them a little while to, bag them, give them a little while to let that work before we start pounding them with more Narcan. So, because it does take a few minutes. If they haven't responded in about 6 minutes, they're probably not going to respond. But not to say that we can't start an IV and give them more Narcan, but just just give it a few minutes to work if you're kind of rolling up at the same time. Bag valve, mass ventilation, support their ventilations, and give them a chance to wake up. And then remember, if we intubate somebody, do not give them Narcan. I know we hadn't done that in a while, but don't give Narcan after somebody's been intubated. All right, sorry, Joseph.
One of the things
Cool. I didn't realize the highway patrol was excellent. Good deal. All right. Oh, one other, that crash that Brian was talking about, just one thing to remember. So if you've got a trauma code that's going to Baptist, it's pediatric. If they're 16 and above, they go upstairs. If they're 15, so it's the same thing as the adult, our protocol. So if they're 16 and above, they go upstairs. I know that sounds weird because they're still pediatric. But if they're 16 and above, they go upstairs. If they're 15 or less, they go downstairs. So that's not that big of a deal. They're going to get basically the same care, except it's going to be adult trauma team versus pediatric trauma team. So if you definitely know that somebody's above or below, so here's what I'd say. If you don't know exactly what age, but they look like they're above 16, I would err on saying we think they're older than 16, and they'll direct you upstairs. And if you think they're under 16, just say that. Just because it does make things work a little easier on the backside once they get there. So just so you know what that criteria is, it's 16's upstairs, 15 and less goes downstairs. That's just for trauma. Right. Just for trauma code. All right. Any other questions about anything? All right, cool. Brian, do you have anything else? All right, cool. Excellent. Thanks, guys.